Back for another conversation. It's been a while. Basically, what we do with these sessions is just since we're young in our careers, we kind of talk through a few cases that we've been working on, we're getting an understanding for. And today we're going to talk about kind of shin splints or medial tibial stress syndrome, or shin splint syndrome, as some people call it. It's kind of a clinical pain condition defined as exercise-induced pain along the posterior medial tibial border. Sometimes people think it's caused by repetitive loading during running, jumping, other things like that. And a lot of the time it can be palpated kind of along around 5 centimeters along that area. Although there's some other people that seem to think there's an anterior shin splints as well. It's usually considered an overuse of tibialis anterior. The pain is then approximately kind of 2/3 of the anterior lateral aspect of the tibia. And then as well as like, there's some people that seem to think that it's pain and discomfort in the leg from repetitive running on hard surfaces or forcibly or excessive use of the foot flexors. And then there's one other kind of group of authors that write a pretty good book for our field, the Bruckner and Kahn fellows. They describe it as a more descriptive term that explains the inflammatory traction event in the tibial aspect of the leg in runners, and more in the medial periostitis of the tibial traction, or simply the tibial periosseous medial. That's a lot. However, we've both seen people with this. You've had it yourself. I'm just going to get into a few more things, and we're going to chat through a couple kind of cases that we've come across. So some people seem to think the risk factors can be broken down into intrinsic and extrinsic. Generally, the extrinsic factors are being kind of sudden and drastic changes in their training volume, so their intensity, their duration, the things like that, the surface, the footwear. Then there's intrinsic factors such as like overpronating, some sort of muscle weakness or a lack of strength, and decreased, dorsiflexion or mobility throughout the ankle. Then the symptoms generally, gradual onset, diffuse pain, increases with activity. Sometimes people get a relief after they warm up, or they run a bit quicker, or decreases a little bit better after warming up. And of course, if they rest for a long time, for a few weeks, and then they go back to running, it can feel a lot better. So before we get into our cases, again, I'll just talk a few things about interventions. You'll add some things for sure. Just avoid aggravating activities. It seems to work for a lot of people. So taking time off running, building back up in terms of the training volume, managing pain, of course, and on what modality you want to choose, a lot work. There's things like taping, orthotics, of course, strengthening, probably one of your main ones, manual therapy, and then walk-run programs. And then, of course, looking at the biomechanics of running. How do you run? How does your foot touch the ground? How are you manipulating the surface that you're running on? So, Bruce, I know I've talked way too much there. For you, a question for you then is, you've had shin splints, you've had some other stuff on your leg just because you've done a lot of running and things like that. Of course, you've seen people with this as well. So what is your experience with this? Talk a little bit about your experience with these kind of things.
Grand. Thank you. That's a very descriptive explanation of what shin splints or medial tibial stress syndrome is. So I'm a good lived example of how to really poorly manage medial tibial stress syndrome. So back in 2015, I was training for my first triathlon event, and so when I run, I should say as well. So I'm, like you're saying with biomechanics, I'm a kind of consciously and deliberately, I'm a 4-foot runner. So this puts more strain and stress through your soleus. So it's kind of to be expected. I'd spiked up my training load quite fast. If you look to the acute chronic work, which but the problem was, because I was very excited for this, my first triathlon event. I'd paid a lot of money for travel and my entry place, accommodation, and everything. I didn't want to not do it. So what I ended up doing was I'd stopped running for maybe 2 weeks before the event, which wasn't enough time for kind of recovery, and then gradually increasing my volume of training again. So rested for a couple of weeks, and then went out to Budapest, and swimming was okay, cycling was a little bit painful, and then I gobbed a few painkillers before the half marathon run, and it was quite sore for a few miles, and then after probably with about 6 or 7 miles to go, it's got this really searing pain up through my leg, and I really kind of hobbled over the line and hobbled to finish the event because I wanted to say I'd done it and get the finisher's medal and all that.
Of course.
So I was extreme pain. For getting the flight home the next day, actually somebody took pity of me in the airport and gave me a wheelchair because I was literally I couldn't really wait there on that leg at all. I was hopping.
Mm-hmm.
So I got a wheelchair to the airport, and then when I got back to Scotland, I went to A&E, explained what, because I thought something severe has happened to you. I explained what had happened, but they said, don't be silly. There's no way you could have had a stress fracture just from running. It's just shin splints. Go home. Then I went to my GP, got her eventually X-ray. It turned out I had a stress fracture in my tibia. So, example, it was absolutely terrible management because I spiked up my training volume very quick in too short a period of time. Didn't do anything to manage the symptoms. I didn't alter anything, and then I went on and carried on with this, putting quite high straining forces through my soleus, gastrocnemius, and my tibia, and it resulted in me getting a stress fracture, and then having a good 4-month recovery off the end of that, where I wasn't able to do any of my normal training or any normal activities. It was a very harsh lesson learned, and but the silver lining to that is that good to reflect on, and now whenever I have any patients or athletes that complain of anything that sounds like shin splints or medial tibia stress syndrome, like you said, so commonly when you do dig a little bit into something, often they'll have just recently gotten motivated to start running again, or they'll have entered it into an event and their training's gone from 0 to 100 too quickly, and it's like it's not kind of very sexy management or treatment, but the best thing to do is just to rein it in and just to gradually increase your training volume, rather than going from 0 to 100.
Absolutely. Yeah, I think I'll just give you a break from talking. There's a great story. You can take many things from that. Similar to not similar to that, but in a sense, the two people that I've seen that are, pretty sure this is what they had, not the stress fracture, but just the shin splints, is that they both just went from, not running to wanting to do 5 and 10Ks, which is great. And you want them to be able to do that. You want them to carry out and get exercise and do what they want to do. However, they just went from 0 to 100, like you're saying, and they didn't kind of necessarily create a gradual training program with considering the ACWR with that. So basically,
because you get really especially when you catch the bug for running, you want to just do it as much as you can all the time.
Of course, especially if you really like it, and it's this time of the year where it's nice out and you want to run outside. You don't want to be on a treadmill, which makes a lot of sense. So when they came in, they're like, yeah, got pain here. This is what that went on. And it made too much sense. So how it worked for me for managing them, it was just, I think like I was telling you earlier, just, I said, okay, we can take a little bit of time off from running. Let's just let the leg kind of calm down. However, what we're going to do is we're going to get you on the bike. You can get your aerobic through that. Then we're going to get you doing, calf raises, split squats, other single leg exercises, glute strengthening. And then gradually we just returned them, gave them a running program to consider slowly building up. So we started with just a couple weeks of tempo run, so running 60 meters, walking back, a little bit of a walk run program on grass, and then we gradually went to concrete and just gradually increased the distance. And some days, you had some more intense days in terms of the intensity of the running, but the distances were still low, and we just gradually built them up. I didn't necessarily, at that point, I wasn't able to do any manual therapy on them just with my job. However, I think maybe that would have been potentially useful depending on what you're doing. But yeah, that's how I manage them. How did you
Funny you should
manage?
see you talk
Sorry.
about manual therapy. We talk about manual therapy there.
Yeah.
It's really I had this one really bizarre experience where
Yeah.
so since I had this problem, I've my calves kind of niggle now and then again,
Yeah.
in the years since. And I think it was a year or two ago when I was in Glasgow and
Mm-hmm.
doing quite a lot of running, training for a marathon.
Mm-hmm.
And kind of similar, in the area described, just medial aspect to the tibia,
Mm-hmm.
and kind of about 2/3 of the way up actually. I
Mm-hmm.
did have a bit of a, it was a bit painful. So actually,
Yeah.
I stopped my run and sat on the bench for a second, and I had a wee poke and a feel with my
I
finger.
remember you telling me about
Yeah.
this.
Oh yeah. Oh yeah. Did I? And
Yeah.
there was this little kind of like this one area where I just kind of put high pressure on and kind of almost frictioned it for maybe 15 and 20 seconds or whatever,
Yeah.
and came off. And it was like a magic touch. I didn't have the pain for the rest of the run, which sounds like complete yeah. But
Yeah.
I don't know what it did and how it worked. I can
Yeah.
like could probably come up with a wish-washy explanation,
Yeah.
but whatever, there's some kind of in some way it kind of modified the pain experience
Yeah.
somehow, and it was great.
Yeah, I know. I could try and theorize and come up with some BS response, but yeah, I don't know enough about manual therapy and the mechanisms of what happened there. But maybe that's a treatment strategy somebody else has been through and they've tried. Wasn't there? Didn't you try some compression, like higher socks
Yeah, I
too?
do actually. I wear compression sleeves in my calves quite
Yeah.
a lot.
Right.
If they're feeling at all kind of niggly or
Right.
painful.
I
Um,
just wear high socks to hide my calves, but you do it for
what
a
calves?
true reason. Yeah, exactly. But yeah, okay, interesting.
Yeah, I do find compression sleeves work. Well, they can have at least a small benefit
Yeah,
in that way.
right
And
on.
another thing, I've used zinc oxide taping as well. Just if you kind of imagine if you start with the tape, kind of medial tibia,
Hmm.
and with a bit of kind of pressure and force, tape it across the way, and put the
Right.
tape onto the lateral side of your
Yeah.
tibia across the anterior part of your leg.
Yeah.
Just to think, because if you're getting that pain because the soleus is almost like the soleus inserts onto the tibia is kind of like
Yeah.
pulling, and that's
Yeah.
the pain. It almost kind of helps cushion it up.
Right.
Once there's less pulling and less painful. So I've tried that as well a little bit just out of interest, and it's
Yeah.
given a little bit of relief.
Right.
But the most important thing, you can take yourself and wear compression socks, but if you continue on
Yeah.
with the same volume of training and don't allow yourself enough time to
Right.
cover, then it's not going to
Hmm.
give you enough help.
Absolutely. So kind of just to not necessarily to conclude, but kind of to make some points for us, the small experiences that we've had, yours have been significantly painful. However, we've kind of identified that there's commonalities here. There that the training load for all the people, including yourself, was just rose too quickly. And from there, that's kind of probably what I would say, with again my limited experience, would probably be the biggest factor here. Any other things that you think could be secondary, tertiary to
Um,
that?
Especially as well, if you had somebody who was consciously changing their running gait
Right.
if they're changing to consciously forefoot run, and it's most they're probably be at quite high risk of this, because
Mm-hmm.
if they're running 20 or 30 miles a week normally and they're
Mm-hmm.
expected to drastically change their running form and
Mm-hmm.
keep doing that volume, the biomechanics are different, so you're making different demands of your lower limb.
Right.
So while they won't like it, you should start them off the
Mm-hmm.
volume, maybe 10 miles, building it by a mile or so per week
Right.
after there. Which
Mm-hmm.
they won't like, but it's good if you have an anecdotal story to hand, say to them, you wanted to, in order to avoid getting injured or being out for a few months, it's
Right.
definitely of interest to take it slow and build it up over a few weeks.
Absolutely. Now I'm going to hit you kind of with a pop quiz or a pop quiz, pop question type thing. If you had, then okay, let's say that we have somebody, not necessarily that has shin splints, but they want to start running. Like it's just an average person. They're kind of active. They don't really go to the gym. They do some stuff here. They're around 30 years old. how do we kind of build them a program? So, okay, they come to us, they say, I don't want to get injured. I want to start running. I just want to be able to run a 5K. How would you go about developing a little bit of a mini running program for them? How would you start it off and basically
Well,
get people on the right track?
I've used it for so many people, even friends and family as well. The Couch to 5K program on the NHS is
Yeah.
brilliant because it's so clear, and it's got audio programs for each run as well that you can listen
Okay.
to. It tells you, I think I can't remember what it starts off in terms
Right.
of walking and running
Yeah.
ratios and
Yeah.
things, but it starts off at a level that really anybody can do,
Okay.
and it's magical, and it just builds up so gradually that they're never absolutely burst. They're never feeling like it's too much for them to manage. And
Right.
the good part as well is you don't keep prescribing certain paces for people to aim for and things, because everyone's so different.
Right.
So it's good in that it's tailored to the individual, in terms of they just run at their own pace,
Uh-huh.
and it's a nice gradual progression. But then it's gradual, but it's significant over a period of the number of weeks that the program runs for. Because then by the end of it, people can run a 5K non-stop.
Nice.
On day dot, that was they absolutely would not have been able to do that at all.
Right. Okay. Cool. So that's something we can maybe when we end up posting this video, we can kind of link that to. I don't think we're gonna have a ton of people watching this. However, maybe one person stumbles upon it and they've had uh you know shin splints and they want to start running again. Maybe they've taken some time off. Maybe they need to have a free program from the NHS that you think is useful. I'm sure it is, and many people have probably had success with. So maybe we'll post that with this video.
Nice.
Right on, Bruce. So I'll just click the stop recording, or maybe you'll stop the recording, and then thanks for taking the time to chat about this.
Thank you. Ciao for now.
Yes, sir.